Hello guys, how are you all? Welcome back to MedSteps YouTube channel. So today we are going to discuss about in general surgery very high yield topic, that is thyroid gland. So this is very important topic in general surgery because this is the main thyroid gland and we can see some thyroid surgical diseases also. So this topic is extremely high yield for MBBS exams like OSCE settings in clinical rotations and in FMGE, NEET PG, and also clinically very important for interns and surgical practice. So what is thyroid gland? If you are seeing here, you can see this is the main largest endocrine gland in the human body and it's located in the anterior neck. If you are seeing here, this is the anterior neck, you can see, and it produces three important hormones. That hormones like T3, then after T4 we call thyroxine, next calcitonin. Okay, so if you are seeing here, this T3 also known as triiodothyronine and T4 is thyroxine, and calcitonin, this calcitonin is very important for because it regulates calcium metabolism. Okay, so we have to remember one thing, thyroid is not just metabolism, it also has a role in calcium regulation, right? So now anatomy. So if you are seeing this picture, you can see here, this is very important for doing like surgeries. If whenever you are going to do general surgery department, that time they will ask that surgical landmarks for thyroid gland. Okay, so that's why this is very important. So if you are seeing the location, the thyroid gland is located from C5 to, you can see T1 till C5 to T1 vertebral levels, and it has a characterized by butterfly shaped. So you can see it look like butterfly shape. And another thing, it has like three different parts. You can see one is right lobe, next one left lobe, and we can see in between this part we call isthmus. And in some patients we can see some like pyramidal lobe like coming like this, one hook like structure, it will come like from isthmus. You can see some extending part we call pyramidal lobe, which is present in about like 50% of patients. We can see this type of pyramidal lobe. So the thyroid gland weight approximately we can say like around 15 to 25 grams, but don't underestimate the small gland, it controls the entire metabolism of the human body. Okay, so you can see here we have some relations of thyroid gland. Whenever any person is have thyroid gland, if you are before doing surgery, we have to know the relations. Relations means for doing surgeries, these are the relations very important for doing like for finding the structure. Okay, if you are seeing, this is the anterior part of the thyroid gland. If you are seeing in this anterior part, you can see skin and platysma, and these are the, we can see, we call strap muscles like homohyoid and stenohyoid. Okay, so these are the things will comes in this strap muscles we call. Whenever we are doing that surgery, that time if you are getting any problem with that, like we are not getting proper visualization of the thyroid gland, then we have to cut. In some cases we have to cut strap muscles, or some cases we have to like retract that strap muscles. Okay, so if you are seeing here, this is the image, you can see it, yeah, you can easily appreciate that anterior and posterior parts. In anterior parts we can see this is skin, and you can see some platysma muscle. Okay, then after you can see some strap muscles. These are the strap muscles, this yellow color structure, you can see these are the strap muscles. Next one if you are seeing, this is the thyroid gland. I am marking here, this is the thyroid gland. If you are going posterior to the thyroid gland, you can see trachea. Okay, so this is the trachea because the thyroid gland is enveloped to trachea. And you can see posterior part, you can see some esophagus, this is the food pipe, and this is the windpipe, and you can see some nerves we call recurrential laryngeal nerves and parathyroid gland in back of the thyroid gland. So, and main we have to remember this thing, like this posterior relations are the reason the thyroid surgery becomes high risk, because they are very prone to get structures get injury. Because of that thing, in during surgery we will get too many complications, or after surgery also while doing surgery, if any person getting problem with that nerve compression or nerve traction, the patient will get problems with voice and many things. Okay, so next we can see here, that is blood supply of thyroid gland. Here the thyroid is a highly vascular organ. You can see here total in artery system, you can see thyroid, the superior thyroid artery. This is the superior thyroid artery, you can see here. This is superior thyroid artery, and this superior thyroid artery branch of external carotid artery. Next we can see this is inferior thyroid artery. The inferior thyroid artery branch of thyrocervical trunk. Okay, and next thing we can see, sometimes if any patient have any EMA artery, if like isthmus or pyramidal lobe, if you are saying, means in some people we can see thyroid EMA artery. So this is thyroid EMA artery is very rare but important for anomaly, because during surgery if you are not suspecting this thing, the patient will get too much bleeding complications. So for this type of EMA artery complication we can see like too much bleeding. Okay, so next we can see here, that is nerve supply of the thyroid gland. If you are seeing here, this is, it look like very simple thing, but because of this nerves, these are the two nerves are very must and very important for remembering, because if you are doing general surgery department, if you are doing surgery, that time we have to focus on external branch of superior laryngeal nerve in superior pole. You can see here, this is, and next one we can see recurrent laryngeal nerve in inferior pole. Okay, so this, if any injury to this recurrent laryngeal nerve and it causes hoarseness, and this is one of the most feared complication in thyroid surgeries. So next I want to share one very important point of view for exams. Here we can see one external branch of superior laryngeal pole. So this one we can see here, this laryngeal nerve will supply the cricothyroid muscles. So this cricothyroid muscles, the main function will be like it will give high pitch voice. So because of injury, the voice will become fatigue and the loss of singing voice, so the patient can't sing. Okay, next we can see, this is the thing that is we call recurrent laryngeal nerve. This recurrent laryngeal nerve is the most important nerve in thyroid surgeries, and it will cause recurrent laryngeal nerve. It supplies like all intrinsic laryngeal muscles except this cricothyroid, because this cricothyroid supplies by external branch of superior laryngeal nerve. So if any patient getting like unilateral like if any patient getting with this nerve getting problem, okay, so the because of that unilateral compression or injury, the patient will get hoarseness voice. In bilateral things you can see like stridor or airway obstruction or emergency. In emergency case, like we have like in tracheostomy, the patient will get problem with this main recurrent laryngeal nerve. So this recurrent laryngeal nerve very important, because in right recurrent laryngeal nerve it loops under the subclavian arteries. You can see here this under the subclavian arteries it will become loop. The left recurrent laryngeal nerve you can see loops under the arch of the aorta, and here the subclavian artery. Okay, they both ascend to tracheoesophageal group. So these are the things. Next we can see here, that is we will discuss little amount of parathyroid gland, because it's important, because whenever patient doing any hemithyroidectomy, that time this is the main concern. Okay, so here you can see in parathyroid gland, this is the parathyroid gland. We can see back of the thyroid gland, this is parathyroid gland. This parathyroid glands have 4 different glands, like superior will be like constant and inferior will be like variable. Okay, so the blood supply will be like inferior thyroid artery is the blood supply. Here this is the inferior thyroid artery is the blood supply, and the clinical importance we can see accidentally removal or patient will get because of accidental removal the patient will get hypocalcemia and it will lead to tetany. And we can see because of that you can see some symptoms like tingling and muscle cramps, like chopstick sign and drowsy eye sign we can see. Okay, so these are the main symptoms because of accidental removing of hypocalcemia, accidental removing of parathyroid gland, the patient will end with hypocalcemia. Okay, so these are the main important things in thyroid surgeries and everything. Next one you can see here, that is embryology. In this embryology, the thyroid gland, like very short, very small embryology concept we have, that is the thyroid gland originates from the pharyngeal pouches. Okay, in pharyngeal arch we can see, in the pharyngeal arch we can see endoderm. In this endoderm, in week 4, when in week 4 we can see the thyroid gland originates from endoderm. Actually it starts from foramen cecum. This is the foramen cecum. In this foramen cecum, this is a foramen cecum, you can see then the foramen cecum will descends via thyroglossal duct, like this it will go down. Because of the thyroglossal duct it reaches the final position at week 7. These are the weeks are very important for our exam point of view. And if duct persists to thyroid glossal cyst, and because of that thing we can see the glossal, because some patients we can see thyroid glossal cyst and it moves with swallowing and tongue protrusion. Okay, so these are the things for embryology. Next one, actually in this video I am only covering the important high yield points for thyroid surgery. Okay, because if you are covering everything like a total deep, it will take long time, because this video I have to complete within like 40 minutes like that. So that's why I'm doing little fast. So next we can see like physiology. In physiology, the thyroid gland main function will be like thyroid hormone synthesis. So first of all we can see here we call hypothalamic tract axis. So here you can see this is the hypothalamus tract. It will release thyroid releasing hormone, then after it will stimulate the pituitary gland, then after this pituitary gland will release thyroid stimulating hormone, then after that the thyroid gland will release T3 and T4, then after patient will get negative feedback. Actually how this thyroid hormone will become synthesis means, we can see in thyroid gland we can see iodide trapping, and we can see oxidation, then after organification, then after MIT and DIT formation, and we can see sometimes like coupling. In this coupling we can see like D3, then after by D4, and then after it will release. Okay, the main function of thyroid gland we can see like increasing metabolism and increasing heart rate and brain development and brain maturation. So these are the main important things in thyroid gland. Next we have to think about capsule of thyroid gland, because this is very important point of view for surgical. Okay, so here we can see thyroid capsule. We can see two different types of capsules. One is true capsule, second one false capsule. So this true capsule from gland itself. Okay, you can see here this is the gland. The true capsule will be like the gland itself, and false capsule will be like from pretracheal fascia. So this is the pretracheal fascia, that is we called false capsule. Okay, now the important surgical fact is the parathyroid gland lies between these two layers. It's very important. Okay, the parathyroid gland lies between these two layers. So during thyroidectomy, if you are careless, you remove the parathyroid gland and the patient will get end with tetany. Okay, next one you can see here in surgical view, it's very important that thing we called Berry's ligament, because this is the main, you can see here, this is the Berry's ligament. This is the main ligament. It's very important, and it's like a very thickening of pretracheal fascia, and it anchors thyroid to cricoid cartilage. Now the most important fact is this recurrent laryngeal nerve runs just behind it. You can see here the recurrent laryngeal nerve runs behind it like this. Okay, so this is this is the most important and most dangerous zone in the thyroid surgery. Okay, so these are the things. Next we can see here, this is lymphatic drainage. In this lymphatic drainage we can see this is like we have 3 different types of lymphatic drainage. You can see here, this is the lymphatics. We can see pre-laryngeal and the pretracheal and paratracheal and deep cervical nodes. Okay, so we can see some superior deep cervical nodes and inferior deep cervical nodes. These are the lymph nodes is very important in while doing surgery and everything. These are the things we have to identify. Next we can see histology. In histology, this is histology image. You can see here the follicles lined by cuboidal epithelium and strong colloid, and we can see some parafollicular cells like C cells protruding calcitonin. Okay, so here in physiology we already discussed, it produces T3 and T4 under thyroid stimulating hormone control, and it involved to metabolic regulation and growth and development, and this parafollicular cells will release calcitonin. So which cells will release calcitonin? That is parafollicular cells for calcium metabolism. Okay, so these are the things. Now we have 2 different types of disorders, that is thyroid disorders is divided into 2 different types of disorders. One is benign and another one malignancy. So in benign you can see like multinodular goiter, colloid goiter, thyroglossal cyst and Hashimoto's thyroiditis and Graves disease. In malignant we can see like malignant papillary in malignant very most common, that is papillary carcinoma and follicular carcinoma and medullary carcinoma and anaplastic carcinoma and lymphoma, and this lymphoma will be like little it will be like rare cases. Okay, so whenever patient coming to you with thyroid gland or thyroid swelling, first of all we have to check normal like thyroid function test and ultrasound. Based on ultrasound results we will discuss what we have to do next, follow up and everything. Okay, next we can see here, that is clinical features. In clinical features the patient usually presents with neck swelling and dysphagia or dyspnea, difficulty in breathing, and stridor in severe cases, and hoarseness if nerve is involved. Okay, so you can see here normal clinical features with normal conditions. If any patient coming with diffuse enlargement, then we have to suspect that is Graves disease or colloid goiter. Next one, some people will comes with multiple nodular or nodular enlargement, then we have to suspect multinodular goiter and solitary nodule. Next we can see thyroid swelling moves with deglutition due to pretracheal fascia and attachments, and it will, if it's the thyroid gland moves with the protrusion of the tongue, then we have to suspect the patient have thyroglossal cyst. The symptoms based on hypothyroidism and hyperthyroidism, the symptoms will be like different. So we have to remember the classical symptoms. We have to remember. If you are not remembering everything, at least the classical symptoms we have to remember. So first of all we can see hypothyroidism. In hypothyroidism we can see weight gain, cold intolerance, constipation, fatigue and decreased sweating, and depression and irritability, and irregular and heavy periods, and slow heart rate, and brittle nails, and puffy face, and muscle or joint pain. These are the everything you can see in hypothyroidism. Next you can see hyperthyroidism. In hyperthyroidism we can see like weight loss and heat intolerance, tremors and palpitations. Along with that like short and light periods, and increased sweating, and nail thickening and flaking, and puffy or bulging eyes, and racing heart, and diarrhea, and nervousness, and anxiety, and muscle weakness. So these are the symptoms of um, hyperthyroidism. So you can see some similar, easily you can remember based on that that gland, how, okay, based on that hormone releasing, the patient will get symptoms. Okay, so next we have some, in malignancy cases we have some features. If you are getting this type of features, we have to suspect the patient have malignancy. Like if you are seeing anything like hard thyroid nodule while doing physical examination, and or fixation to surrounding tissues, or if you are suspecting the cervical lymph nodes affected or rapid growth and hoarseness, then we have to suspect patient have malignancy. Okay, so these are things. Some patient will get pressure symptoms, we already discussed this, the dysphagia and dyspnea and hoarseness, and you can see this type, and if the size is increasing more, then we have to go with cosmetic concern. So next we have diagnosis. The diagnosis will be like step by step. If any patient coming with this thyroid swelling or enlargement, we have to go with thyroid function test, like for checking T3, T4 and TSH, and ultrasound neck. This is the main investigation of choice. Next, the gold standard will be like 5 needle aspiration cytology, FNAC, very important for gold standard. So we have to remember the FNAC is the most important diagnostic test for finding thyroid nodules. So here we can see the radionucleoside scan for finding hot versus cold nodule. In severe cases, we can do CT or MRI for retrosternal and extension or local invasion, and calcitonin if suspect medullary carcinoma, and serum thyroglobulin for recurrence of follow-up. So these are things we have to do. So in investigation, one case, for example, one patient came to you. When the patient is coming to you, you did you did some proper assessment. Then after physical examination, then you are suspecting some thyroid nodule or multiple nodule or a cyst. That time what we have to do, we have to check the thyroid function test. Along with that, we have to do ultrasound. When you are doing ultrasound, in that ultrasound you will get the thyroid score. Okay, what it means? The thyroid score means, so after the patient is coming, we have to do one test. The test we called ultrasound. In that ultrasound, the ultrasound people will give one thyroid score. Thyroid score means it's like TI-RADS. This thyroid means thyroid imaging reporting and data system. So this thyroid classification will help to find the thyroid nodule, it's like benign or malignancy. So based on that, we can do follow up then after management. Okay, so in the thyroid classification, how they are going to do means based on 6 important things. That is, first one, composition. In this composition, they are finding that nodule is cystic, almost like if it's completely cystic means then we have that like 0. If it's spongiform, that they will mark like that's 0, and if it's like mixed cystic and solid means then they will give like 1 mark, and it's solid or almost completely solid means they will give 2 marks. Next one we have to see, next they are going to focus on echogenicity. Echogenicity means anechoic like 0, and hyperechoic and isoechoic will be like 1, and you can see hypoechoic, that is 2, and very hypoechoic means that is 3, and it's like darker than staph muscle, then they are suspecting that is 3. Okay, next based on shape, if it's too much wide then tall, then they will give 0. If it's taller than wide, then they will give 3. Okay, if its margins will be like smooth, it will be like 0, and it's ill defined, then they will give 0, and it's lobulated and irregular, then they will give 2, and the extrathyroidal means they will give extension equal to 3. And next in at final, like echogenic fossa, this is the main thing, the large large comet tail artificant, then they will give 0, and if they are suspecting like micro calcifications, they will give 1. If it's like peripheral or calcium, they will give 2, or like punnetate or echogenic foci or like micro calcification they are suspecting, they will give 3. So these are the main thyroids classification. After, based on the thyroids classification, they will mark that is like thyroids 1 or 2 or 3. So based on that, then after we have to check with Bethesda. This is the main thyroid criteria. Based on the things, we are going to do Bethesda classification for doing fine needle aspiration. So here thyroids this category, based on this thing we are going to do follow up. So we have total some points. If the thyroid score will be like 0, that means the thyroid 1 is like malignancy risk will be like 0%, and the suspicious level will be like benign, and no, in management, no fine needle aspiration or follow up. Okay, so no need. So after 6 months we have to call that patient back for rechecking or ultrasound, for doing ultrasound. If you are if the thyroid score will be like 2, the points will be 2, the malignancy risk will be like less than 2%, and the suspicious will be like not suspicious, and the management will be like no fine needle aspiration cytology. Next we can see thyroid 3, the point will be like 3, the malignancy risk will be like 5%, and the suspicious level will be like mildly suspicious, and the management will be like if the nodule will be like greater than equal to 2.5 centimeters, follow up if greater than equal to 1.5 centimeters, we have to do follow up. If it's like greater than equal to 2.5 centimeters, we have to do fine needle aspiration. Okay, if the thyroid, if you are suspecting like thyroid 4, the points will be like 4.4 to 6 points. What are things we checked in in ultrasound, they will give 4 to 6 points, that then we have to suspect that is thyroid 4 category. So the malignancy risk will be like low, but it will be like suspicious. So 10 to 20% of malignancy risk, the moderate suspicious, we have to do fine needle aspiration if greater than equal to 1.5 centimeters, or we have to follow up with if greater than equal to 1 centimeters. Then after you can see thyroid 5, like greater than equal to 7. So the malignancy risk will be like greater than 20 to 35%, that is highly suspicious, the fine needle aspiration if greater than 1 centimeters, and follow up greater than 0.5 centimeters. After doing fine needle aspiration cytology, we have to send that report for Bethesda. For cytology, they will give Bethesda classification. So this Bethesda system for reporting thyroid cytology. Okay, so if that is like we have total 6 different types of Bethesda categories. If Bethesda 1 category will be like undiagnostic or unsatisfactory, after that we have to repeat after 6 months we have to repeat fine needle aspiration cytology with ultrasound guidance another time. Next one you can see Bethesda 2, it will be like we are suspecting benign cyst or benign nodule. So it will be like clinical and sonographic follow up we have to do. Next one you can see Bethesda 3 undetermined, we have to repeat fine needle aspiration and or molecular testing or lobectomy. Next we can see Bethesda 4 undetermined, we have to do molecular testing or we have to go with surgery, that is molecular testing, then after we have to go with lobectomy. Okay, so next one, if you are suspecting like Bethesda 5, if you are suspecting malignancy, we have to total remove that thyroid gland near a total thyroidectomy or lobectomy we have to do. Next Bethesda 6 will be like malignancy, so near total thyroidectomy or lobectomy we have to do in Bethesda classification. So after Bethesda classification, if you are approaching to thyroid nodule, always follow the sequence based how we discussed. Like first one, proper assessment, history taking and physical examination. Then after we have to check with the thyroid function test. Then after ultrasound. After ultrasound we have to go with thyroids category. Based on the thyroids category, then after we have to do Bethesda, we have to rule out based on Bethesda classification, we have to do fine needle aspiration cytology. Then after we have to check with Bethesda category in which Bethesda category the patient have. Based on that we have to do diagnosis. Then after we have to do surgery or conservative management. Okay, so these are the things. Now management. In general management we have to do like we have to give iodine supplements, and if patient like smoke, we have to stop that, we have to counsel that patient to quit the smoking. Then after we have to give proper nutritional support, and based on the patient thyroidism we have to do management. Like for hypothyroidism, we can treat that patient lifelong with levothyroxine. For hyperthyroidism, we can treat that patient like with first line drug will be like methimazole or carbimazole based on the TSH value and based on symptoms. If patient getting like thyroid storm, we can treat that patient with emergency treatment like propyl thiouracil or propranolol or iodine. Okay, or we can, in severe cases like radioactive iodine, we can do like mainly in Graves disease and toxic nodules, we can do these things. Next, we have one classification that is we called Goiter classification, like simple goiter, toxic goiter and neoplastic goiter. So in simple goiter we can say diffuse or nodular. Next we can see toxic goiter will be like Graves, toxic, multiple nodular goiter and toxic adenoma. In neoplastic goiter we can see benign adenomas or carcinoma. Next, indications for surgery, but before that thing we have to know why we have to do surgery to the patient. Patient have like too much symptomatic, then we have to do surgery, like if it's proven, the patient proven like patient have malignancy or suspected, a large goiter with pressure symptoms like dysphagia, okay, and dyspnea or hoarseness, then we have to do surgery. And cosmetic disfigurement and toxic goiter not controlled medically, or solitary toxic adenoma and thyroglossal cyst. Okay, so these are things we have to do. Now the most important surgical section is that is hemithyroidectomy. Okay, in hemithyroidectomy we can see also known as lobectomy. We are doing this thing for solitary nodules, and we have another thing that is types of thyroidectomy, that is total thyroidectomy. The total thyroidectomy for thyroid cancer, Graves disease and multinodular goiter, and if you are suspicious lesions, then we have to do total thyroidectomy, and it's like bilateral disease, example for suspecting carcinoma, then we have to do. Next we can see here that is subtotal thyroidectomy, like it's used less now and it's replaced by total thyroidectomy. Next one we can see near total thyroidectomy, that is leaves tiny remnant on one side for metabolism, and or we can see isthmusectomy for small lesions in the isthmus. Okay, next one, these are the steps of thyroidectomy. You can see here, first it's very simple, but we have to remember the steps, because in ASCII settings the doctor will ask the steps of thyroidectomy and everything. So that's why these are the things very important. First we have to do pre-op assessment, then after we have to then after the anesthesia people, the anesthesia doctor will do pre-op assessment, and the patient will be in neck extension position, and after anesthesia, after giving proper positioning, then we have to start with surgery like skin incision. The skin incision we called Coker's collar incision, and we have to raise the subplatysma flaps, and we have to separate the strap muscles. The strap muscles we can see like sternocleidomastoid, omohyoid, thyrohyoid and sternothyroid. So these are the strap muscles we have to separate. If you are getting problem with visualization, if the strap muscles are tight, you can cut also. Then after we have to identify and preserve the recurrent and external laryngeal nerves, because these are the nerves very prone to get injury. Okay, because the recurrent laryngeal nerve, the left recurrent laryngeal nerve, we can see beyond that various ligament it will pass, that's why. Next we can see parathyroid gland. We have to do ligation of superior and inferior thyroid pedicles, and we have to close to the capsule. Next we can see here, we have to remove the lobe or isthmus based on the surgery indicated. Then after we have to achieve that hemostasis. Then after we have to place drain in if needed. Then after we have to close in layers. Okay, so these are the steps of thyroidectomy. Okay, these are the steps are very important in ASCII station. So next we can see some complications of thyroid surgery, that is the patient have based on, okay, if you are in ASCII setting, if the doctor is asking tell me the complications of thyroid surgery, we have to divide that complications. Like for example, the immediate you can see hemorrhage, and the patient will get airway obstruction or hematoma. Okay, So because the airway obstruction because of airway risk compromise. Next we can see in early complications we can see hypocalcemia, okay, and recurrent laryngeal nerve injury. In hypocalcemia due to parathyroid gland damage, and we can see some signs. The signs we call swastik sign. Swastik sign means if you are tapping same to same, if you are tapping on zygomatic area, the patient will get twitching of the eye. Okay, so this thing we call swastik sign. Why? Because of reduced calcium. Hypocalcemia will cause this type of things. Next we can see Trousier sign. Trousier sign means if we are check how we check blood pressure, same to same like that. If we inflate, the patient will get this type of wrist flexion and the thumb and index finger opposing. So this is this condition we call Trousier. This sign we call Trousier sign. Okay, why the patient is getting? Because of hypocalcemia. Okay, and recurrent laryngeal nerve, we can see the patient will get hoarseness voice. Next we can see late complications, like we can see hypothyroidism and permanent hypoparathyroidism. Okay, so these are the things. Next we can see thyrotoxic crisis, like patient will get thyroid storm and wound infection and scar problems also. So in nerve injuries, the clinical signs we can see like the recurrent laryngeal nerve will be like hoarseness, and bilateral recurrent laryngeal nerve will be like airway obstruction, and external laryngeal nerve injury we can see like loss of high pitched voice. Okay, so the high yield exam point of view is very important things is the most common thyroid cancer will be like papillary carcinoma, and for doing for checking the thyroid nodule and everything, the best investigation will be like fine needle aspiration. And we can see the recurrent laryngeal nerve is the most common injured nerve because it's like loop we can see, and most common complication will be like hypocalcemia because of thyroid surgery, and we can see most dangerous complication will be like post-op hemorrhage and it causing airway obstruction. Okay, so if any patient telling like if while doing physical examination or assessment, if thyroid moves with deglutination, we have to suspect the patient have thyroglossal cyst. Okay, so these are the things. So in this video we covered everything about the thyroid gland. So in next video I will upload how to do physical examination of thyroid gland. Then after we will discuss everything, which as usual I already announced that we are going to start general surgery series. Why? Because many students are messaged me like how you teach like that, please teach me like that, they requested, that's why I started another time. So in this maybe in this 1 month we are going to complete every thyroid, every general surgery topics. So we will meet in our next video. Till the time, take care, bye bye, thank you.